Now, before we get started, I'll introduce our speaker. Dr. Emily Ferguson is a postdoctoral academic researcher at Stanford University's Autism and Developmental Disorders Research Program. Her work takes a comprehensive perspective, integrating methods from implementation science to improve the accessibility and quality of clinical care for underserved autistic populations, especially those with higher support needs. And now I will turn this over to our speaker.
Hi, everyone, and thank you so much for the welcome and for having me here today. I am excited to present to you and talk to you about a topic that is near and dear to my heart. This topic is exploring self-regulation strategies for self-injurious behaviors in autistic individuals, really across the lifespan. I'm going to start off by just sharing a little bit about my own positionality. So, I am a postdoctoral researcher and clinician at Stanford University. My PhD is in clinical psychology, so I work in clinical practice as well. When I work in clinical practice as a therapist, I'm primarily working with kids who are diagnosed with autism and co-occurring intellectual disability. So that's the clinical population that I primarily work with. Though I have worked with autistic individuals across the cognitive ability range. I am not autistic myself. I am a family member to autistic people and also have worked with many autistic people. So to start off, I'm going to talk a little bit about self-injurious behaviors in autistic individuals. And I'd like to mention here that the first half of this talk will be more dedicated to research findings, and the second half will be dedicated to practical implications for clinical practice, for parenting, for being an autistic person. So I'm hoping to weave together the research and the practical implications in this talk. So to start off, we know that self-injurious behaviors, or SIB, are present in upwards of 40 to 50% of autistic people across the cognitive ability range. So ranging from those with co-occurring intellectual disability to those with above average intelligence. We know that SIB are heterogeneous and complex and often persist in varying forms and intensity across the lifespan. When present, SIB greatly increase the likelihood of tissue damage or physical injury, hospitalization, and more restrictive residential placements when the SIB is very severe. So, SIB are often included in the domain of restricted and repetitive behaviors, or RRB, in autism due to the fixed and repetitive nature of many SIB typographies. Typographies is just another way of saying types of SIB. So, I want to just pause here for a moment to emphasize that in this talk, I am focusing more on repetitive forms of SIB, and I will show in the next slide some examples of those. This might look a little bit different from self-injury that takes the form of cutting oneself with a razor or those types of self-injurious behaviors. So, some examples of these repetitive forms of SIB and autism include repetitive head banging, self hitting, skin scratching, hair pulling, lip or cheek biting, nail biting, skin picking, and hitting oneself against hard objects. And as I mentioned before, these are more repetitive forms of SIB, and in really extreme forms, when somebody is headbanging very often or hitting themselves very often, intervention might be required, such as a helmet to predict to protect against severe injury. So there's currently really limited understanding of correlates of SIB in autistic youth to inform better prevention and intervention efforts. So while there's been some different hypotheses about what might drive SIB in autistic individuals, we still have a lot of different findings out there in the literature. And one possible reason for this is because highly diverse types of SIB, like I showed you on the previous slide, all those different types of SIB, head banging, skin picking, are often combined and looked at together. And so this doesn't give us a great sense of what individual features are linked to greater severity of distinct types of SIB. So what's linked to greater severity of head banging, for example. So there are some suggestions in the literature that features such as lower speech production, lower cognitive functioning, greater emotion dysregulation, greater sensory hypersensitivity, sex, and age are linked to greater severity of overall SIB. However, as I mentioned, these findings are inconsistent, so we're not clearly seeing across papers the same trends. And it is still an open question of what are the patterns of associations between these features and unique types of SIB in autistic youth. So I'm going to turn to discussing some research that we conducted over the past year that explored this question. And just to mention, this research has been recently published, and I will share the article with Denise so that you can access it if you're interested in reading it more specifically. So, moving into the aims of the study, we first sought to identify the frequency distribution of unique types of SIB in a large sample of autistic youth. And then we aim to characterize the associations between developmental and clinical characteristics and unique types of SIB. So parents of almost 600 autistic youth completed surveys through Spark Research Match. And for those of you who aren't familiar, Spark is a large nationwide study that is trying to better understand genetic links of autism. And they also, as part of participating in Spark, families can consent to be contacted about other research studies. And so families across the US were contacted to complete survey measures. Youth in this sample were between 3 to 18 years old, 13% female, and 24% with co-occurring intellectual disability. And so in this study, we looked at speech level, cognitive functioning, emotion dysregulation, and sensory hypersensitivity as predictors of each of the 11 types of SIB using generalized additive models. And I'm just going to pause here for a second because I see some chats coming in. Denise, is there anything that I need to address here?
We can tackle those at the end.
Okay, great. Thank you. Okay, so briefly for some additional demographic information, most parents in this sample were college graduates, but education spans from partial high school completion to a graduate degree. And we had a relatively equal distribution of household incomes in this sample. For an overview of the measures that we used, we captured SIB using item-level data from the SIB subscale of the Dimensional Assessment of Restricted and Repetitive Behaviors, or DARB. If you're interested in learning more about this measure, it is available open access through Stanford's website. We can also provide that as part of materials from this talk. But this measure looks at different domains of restricted and repetitive behaviors, including SIB. and it captures 11 different types of SIB, which I'll be showing you on the next slide. We also captured dysregulation and hypersensitivity using questionnaires for that purpose. So moving into the results, this slide shows the endorsement frequency for each type of SIB captured by the DARB measure. So you can see here that scores for each item range from not at all a problem in blue to very serious or extreme problem over on the right here in red. And as you can see, roughly 30 to 50% of caregivers reported mild to severe concerns for many of the SIB typographies. So I really want to highlight here the importance of looking at the severity of each type of SIB rather than just looking at whether someone has overall severe SIB, because then you'll get a clearer picture of which types of SIB might be a very serious problem and which types are not really a problem at all. And so moving into the findings from the GAM models for each type of SIB, this slide here is here to show that there were different patterns of associations for each SIB typography. And then I'm now going to move into the findings for each predictor in more detail and come back to this later. And just briefly, for those who are less familiar with GAM models, they can be best understood in the context of linear modeling or linear regressions. So moving into the findings for the GAM models for dysregulation, you can see here that higher severity of dysregulation was significantly associated with greater severity of 9 types of SIB, ranging from self-hitting to skin picking. So when we think about emotion dysregulation, we're thinking about difficulty responding to strong emotions, difficulty calming down in response to strong emotions. And so we're seeing here that greater dysregulation is associated with greater severity of most types of SIB that we captured in this sample. And this slide shows the significant effects of dysregulation on these 9 types of SIB. So again, as dysregulation increases, the severity of these typographies increases. So here you can see that higher sensory hypersensitivity, so greater sensitivity to sensory stimuli in the environment, such as loud noises, was associated with greater severity of self-scratching with and without tissue damage, repetitive hair twirling and skin picking, and lip biting with and without tissue damage. And so this indicates that these types of SIB might be a means of self-soothing or communicating distress in response to overwhelming sensory stimuli. So it's possible that someone might engage in repetitive hair twirling when they're overwhelmed by loud noises in the environment, and it's a way to self-soothe. So we also looked at the role of cognitive functioning in the manifestation of different types of SIB. And you can see here that for cognitive functioning, lower IQ was associated with greater severity of self-scratching, self-hitting, and lip biting with tissue damage. So these findings suggest that the presence of intellectual disability might increase the risk of engaging in specific types of SIB. And it's important to highlight here that self-hitting is one of the more severe forms of SIB that could result in injury to oneself. And so it's important to note that that could be more present in people with intellectual disability. I also want to highlight here, just if you're looking at these items and thinking of and noticing, oh, There's lip biting with tissue damage as one item, and there's also lip biting without tissue damage as another item. The DARB measure was designed to capture some types of SIB that result in tissue damage or severe injury, and some types that don't. And so then moving into the last result slide that I'll show you today, for speech level, youth who speak in full sentences demonstrated lower severity of self-hitting and headbanging than youth who use no words to communicate. So these findings suggest that autistic youth who use no words to communicate might be more likely to engage in specific types of SIB. So again, similar to those findings that I highlighted for intellectual disability, we might also see that people with intellectual disability who are non-speaking are also more likely to hit themselves or to engage in headbanging. And there's a lot of possible explanations for this. One could be that it's a way of communicating their needs, and self-hitting and headbanging often get a response from other people because they are severe and they have the potential for serious injury. And so they can become an effective way of getting responses from other people. But again, that's just one possible explanation for why someone might engage in these behaviors. There's many possible explanations for why people engage in SIB. I also want to highlight here that these findings are parent report based on behaviors of their youth. And so a little bit later, I'll talk about some findings from another study that looked at the self-report of autistic adults. So now I'm returning to this slide that I showed you before in order to summarize the findings. So this table highlights the significant positive associations, significant negative associations, and non-significant associations. So first off, these findings highlight that we can gain important insights from looking at predictors of the severity of unique types of SIB rather than overall SIB. So once again, you can see here that we looked at 11 types of SIB, and then we looked at predictors, whether these 4 variables predicted each type. And so we found some similarities and differences in the role of dysregulation and hypersensitivity. However, overall, greater emotion dysregulation and greater sensory hypersensitivity were associated with greater severity of most types of SIB. And these findings align with prior research that SIB is linked to arousal and may serve as a means of responding to or communicating strong emotions. So research has found that SIB is often associated with arousal. Our findings also show that lower IQ and lower speech level are associated with greater severity of self-hitting and headbanging. And as I've already mentioned, this is an important finding to note because both behaviors have the potential to result in significant physical harm or tissue damage. And we are currently working on a project right now that looks at predictors of types of SIB that have the potential to be more immediately injurious, to result in more immediate injury, versus ones that could result in injury over time. So for example, self-scratching might be okay on one day, but if you scratch the same spot over and over again for many days or months, it could result in bleeding or scarring. So I really hope to highlight here that the origins of self-injurious behaviors are complex and multifaceted. And these are just 4 of the many questions that we might ask when we're working with autistic people who also engage in SIB. So thinking about their mental health and their emotion regulation skills. Is the situation placing demands that exceed emotion regulation skills? So for example, is the person in a situation where they're feeling very emotionally dysregulated, but they don't have other skills to cope, and so SIB feels like the best way to cope. For sensory dysregulation, is the behavior in response to unmet sensory needs? So, for example, does the individual feel like they need more sensory input in that moment? And so they're self scratching or skin picking or hair twirling? Or is it in response to sensory overload? So, are they hitting themselves because they're overwhelmed, overloaded? It's important to think about cognitive capacities. And so, as I mentioned in the beginning, in my clinical practice, I mostly work with individuals with co occurring intellectual disability. And so, we need to think about, are the demands on this person too high or too low for their cognitive level? So, for example, is someone asking them something that they just don't understand and that's frustrating? Or in the reverse, is someone not expecting enough of them? And that's also frustrating. And then we need to think about the adequacy of someone's communication system as well. So if someone is non speaking, do they have another functional way to communicate? Have they tried using an AAC device? Have they tried using picture cards? Have they tried using gestures? Have other people worked with them to see, do they have another way to communicate their wants and needs to me so that it's not just relying on their behaviors to communicate their wants and needs? And so, as I mentioned before, I also wanted to highlight that adults have reported on the function of self-injurious behaviors. And I want to highlight here that this is not my research. This is research out of Mosley's group in the UK. And I'm also happy to share the link to this research as well. This is a table that I copied directly from their paper, and the authors are listed at the bottom here. So in this paper, Mosley and her group spoke with autistic adults and asked about the roles of non-suicidal self-injurious behaviors. So where I've been talking about more repetitive types of self-injury, they were also asking about types of self-injury such as cutting oneself, eye gouging, other types of self-injurious behaviors. And they listed here example answers to the question of, I hurt myself, dot, dot, dot. And adults reported, I hurt myself, dot, 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 to feel something, to change my emotional pain into something physical, to relieve stress or pressure, to deal with frustration, in the hopes that someone would notice that something is wrong or so that others will pay attention to me, to shock or hurt someone, as self-punishment, so I do not hurt myself in other ways because I get the urge and I cannot stop it, to get a rush or surge of energy. So these are other possible explanations for why someone might engage in SIB. And again, I'm happy to share the link to this article out of this group so you can learn more. So I'm going to move here just to talk briefly about a type of therapy called dialectical behavior therapy. And again, I'm a clinical psychologist by training. My time is split 80-20 between research and clinical work. So I do 4 days a week of clinical research, 1 day a week seeing autistic clients. So clinical work therapy is always informing what I do every day. And so dialectical behavior therapy is one type of therapy that was developed originally for people with borderline personality disorder. And the reason why I'm bringing it up here is because it's often a first line treatment for people who are engaging in suicidal behaviors, who have thoughts of suicide, who are engaging in non suicidal self injurious behaviors or other forms of self injury. It is applicable really to people across the spectrum of life. So it wasn't developed originally for autism, but applies to autism as well. And one of the key tenets of this therapy is that people are doing the best that they can. And what this means is that in any given moment, with the cognitive capacity someone has, with the speech capacity someone has, with the self regulation strategies that someone has, they're doing the best. And so the best in one moment might look like self hitting. Now, a really important part of this therapy is also change. So it's not saying that we are just going to accept self harming behaviors and not try to change them, but it's saying that we're going to accept that they happened in that moment and then think about how we can change them. And so I think this is just a nice framework for thinking about repetitive behaviors as well, where we can accept ones that are serving a good function for that person. And then we can also notice ones that might need to be intervened on because they're causing serious harm or putting that individual at risk. So I'm posting here an example of a pathway from poor emotion regulation to challenging behaviors or self-injury. And so the idea here, as I mentioned in our research findings, is that greater emotion dysregulation is often linked to greater likelihood of engaging in different types of SIB. And here is just one example of how this pathway could go. So you have an individual and they have their individual factors. So maybe they're kind of hungry and tired that day, and their parent takes them to a grocery store. And they get to the grocery store and there's a precipitating queue. So somebody accidentally knocks over a bunch of cans and it's really loud. Let's say that that individual then has difficulty identifying and labeling their emotions. So identifying the emotion might be, this is really overwhelming. I need to get away from this situation. But they have difficulty doing that. And let's say they also might have limited self regulation skills. So they don't have a coping strategy in that moment, like removing themselves from that situation or taking 3 deep breaths or putting on headphones to block out the noise. And so as a result, the negative emotional the negative emotional experience just continues, and it might even increase in intensity. And as a result, the person's anxiety might go up as well. And then they might engage in one of these behaviors. So they might then start hitting themselves or banging their head. There could be other types of behaviors that emerge as well. This is just one example of a pathway from poor emotion regulation to challenging behaviors, or SIB, that kind of highlights the role of emotion regulation. So, what does this all mean? What can we do about it? So, thinking about the role of self regulation in self injurious behaviors, we want to think about how we can really practice emotion regulation skills. And so, one key component of practicing emotion regulation is being aware of our emotions. And this is a hard skill in general. I don't know about you, but sometimes I have a feeling and I'm not quite sure what it is. And so, we want to do a lot of practice using feelings charts and emotion labeling to figure out what the emotion is and to build awareness around it. So statements such as, I'm feeling sad. And if you're a caregiver, you can model this for your children by labeling how you're feeling when you're feeling it in the moment. We also can practice emotion regulation strategies, so practicing coping skills daily, practicing co-regulation strategies, so coping with your child, and then also thinking about prevention strategies to reduce the likelihood of putting someone in a situation where they feel distressed. And I'll give some more examples of all of these. So, for that first part of emotion recognition, it can be really helpful to put together a personalized feelings chart. And this chart can start at the bottom with feeling calm and happy and work the way to the top where someone's feeling angry and very dysregulated and distressed. And then the task is to fill in what that looks and sounds and feels like for that individual person, and then what that person needs in the moment. And so this is an example of a chart that I made with one of my clients and his family. And again, this can be very personalized so that you're labeling what happens at each emotional stage and the best way to respond. And then, as I mentioned, coping strategies can be very helpful as well. And especially when we're thinking about working with autistic children, we can't expect children to be regulated if the whole family is not regulated, if the whole family is not working with their emotions. And so, family sessions can be really useful. If an adult is still living with their family and they want their family to participate in therapy, it can be very useful for adults as well. Here, I've put up some co-regulation techniques. This is a chart that's freely available online through UC Davis Health. And these are examples of strategies that caregivers can use with children or adults if adults like it and want it. So, labeling feelings, breathing together, doing calming body exercises, listening to soothing music, maybe doing a sensory activity. Parents can do a lot of modeling of using coping strategies. Therapists can do this as well. There's also a video, I'm happy to share the link for this after the talk, from DBT that focuses on the tip skills, which is another type of coping strategy. And then, as I've mentioned throughout this talk, we want to be thinking about an individual's cognitive level and speech level. And so we also want to think about, is this individual able to learn on their own how to use a coping skill in the moment when they really need it? So this, again, can be a hard skill for so many people. I'm sure we could all think of a time when we could have used a coping strategy but didn't. And so it's just thinking about, how can we work with autistic kids and adults to have a better sense of when a coping skill is appropriate and how to use it in that moment. So, also thinking about prevention strategies here. So, this worksheet I have copied from the Research Units in Behavioral Intervention Protocol, or RUBY. And again, this is a link that's freely available online with all resources or all worksheets from the intervention available online. One component of this intervention is thinking about prevention strategies. So, let's say that you notice that your child always engages in headbanging at the movie theater. Maybe they're trying to communicate something about the movie theater. Maybe it's too overstimulating. They don't like the way it smells. They just don't like going to the movies. And so you might figure out, okay, maybe this is just a place we're not going to go. We're going to watch movies at home instead. You might also think about the order of events. So let's say that your child always engages in SIB when they have to switch from TV time to homework time. You might put the homework time before the TV time, so the reward is coming after. Again, I'm talking about parents with a kid, but this can also apply with adults. We can think about addressing setting events. So, for example, if you know that your child or you yourself as an adult are more likely to engage in SIB when you haven't slept well the night before, then you might be thinking about how to get more sleep that night, maybe making some adjustments throughout that day to accommodate the lack of sleep. And so there's also a lot of behavioral interventions that can help to address self-injurious behaviors. So functional analysis of problem behaviors is a strategy that's been used widely in autism work. And the idea is that you're trying to identify the antecedents, behaviors, and consequences. Again, this is not specific to autism. So, in dialectical behavior therapy with suicidal teens who are not on the autism spectrum, you might also see that parents are working to identify what happens before a self cutting episode and what happens after the self cutting episode to try to decrease the frequency of those episodes. So, this is the strategy that's used commonly in a lot of therapies and can be helpful for identifying, oh, we notice that we always give Billy what he wants after he engages in headbanging. He might be making the connection that headbanging gets him what he wants. So, how can we disrupt this cycle so that he's requesting what he wants and getting it for the appropriate request instead of the headbanging? I also just want to acknowledge that I know that there are mixed feelings about behavioral therapy is more widely in the autistic community, and that some people have more positive views of these therapies, some people have more negative views of these therapies. I come from the perspective that if you're delivering any of these therapies well, you're doing it in a strength-based way where you're identifying the needs of the person in front of you and you're trying to help them with the behaviors that are most impacting their quality of life and their family's quality of life. So if somebody is self-hitting to the point where they're getting head traumas and it's really concerning for the family, we want to think about how to help reduce the impact of that. And so mental health therapies can also be really helpful. There's adapted forms of cognitive behavioral therapy that can be useful. We can, for speaking autistic individuals, we can do CBT directly with them. For non-speaking autistic individuals, it's often helpful to have a parent or caregiver present. And then, as I've mentioned, there's also parent training in behavior management. So I mentioned the research units in behavioral intervention or Ruby program and some of their prevention strategies. Another therapy that's very helpful for disruptive behaviors more broadly is called parent-child interaction therapy. This is for children aged 2 to 7. So this is a younger focused type of therapy, but it's very focused on developing a strong relationship with your child and then thinking about how you can help increase their compliance with directives and reduce the frequency of self-harming or other challenging behaviors. So this is my last slide for the day, and then I should have time to get into questions. So this is a list of resources once again. These are not necessarily self-injurious behavior specific, but I know that a lot of times self-injurious behavior can also show up alongside behaviors such as aggression or property destruction. And so I just wanted to point out a few resources. Autism Speaks does have a safety kit that you can look at freely available online if you have concerns about behaviors. They also have a challenging behaviors toolkit that has a lot of resources available for parents and clinicians and educators. There's also an echo that has been developed. So echoes are designed to train psychiatrists and other professionals in specific skills. And there's one that's been developed specifically for challenging behaviors in autism. So you might be interested in joining that as well. Again, we can share these links after the talk if these are of interest, but I just want people to know about some of these freely available resources that are out there for SIB and other types of challenging behaviors in autism. And so with that, I would like to thank my research team. Again, the first part of my talk focused on research that I've done over the past year or so. So thank you to my team, my postdoc mentor, Dr. Antonio Hardin, the funding we had for this project. And then my email is eferguso@stanford.edu if you are interested in getting in touch. And with that, I will open the Q&A and see what questions we have in there.
Emily, would you be willing to leave your contact screen open so that people can grab that?
Okay, sure.
Yeah, if you can put that slide back up, that'd be great.
Okay.
That's perfect. Thank you.
Okay, great. Okay. Okay, so we have a question here. I'm an autistic adult who regulates himself with meditation, martial arts, breathing, writing, and sometimes even calligraphy. Because of that, is it fair to say that this presentation will be about regulation strategies that can be used in a matter of minutes or less? Thank you for that question. That's a great question. Those are fantastic regulation strategies. And I think that it is important to have regulation strategies that can be used in a matter of minutes or less, like you're saying. So, breathing is one that could be used in a matter of minutes or less. Meditation as well. Something like martial arts or calligraphy, you might need more time for that. But definitely important to think about what is your go-to regulation strategy when you're in a pinch and you don't have a lot of time, and what's a good strategy when you're just having a hard day and you've got 30 minutes and you're going to go do something that is useful for you. Thank you for that. I see that we have a question about MTT treatment. I am actually not familiar with MTT treatment. I will come back to that if we have time to discuss. Does skin picking include releasing ingrown hair on the legs in females and picking nostrils with long nails? Thank you for those questions. Yes, those are examples of skin picking, and it looks like we had a nice question or a nice response from one of our attendees as well. Thank you for responding to that. So there's a few questions I see about the epigenetic piece. That is not something that we looked into. It's a good question, though. We also didn't look into links between allergies or nutrition or types of SIB. We had a question about where does self-biting fall? Thank you for that. I believe that, well, you're right. That's not one that's captured by the DARB measure that we use in this study, but is definitely a type of SIB that we should consider including. So I made a note of that. Thank you. So we had some questions about biomedical causes or medical causes of SIB. This is a great question. So this study did not really look at links between medical issues or pain and SIB, but that is definitely another possible cause of SIB. So if somebody is having intense gastrointestinal pain, that could be a reason why they're engaging in SIB. And there is other research that is happening in Philadelphia right now, looking at some of those questions. And again, I'm happy to share some resources around that. But definitely the piece of physical pain and possible links to SIB is something that's important to look at. And then another question too about this more pain tolerance encouraging SIBs. And this is another great question. There is some research out there that's looked at this, and this is one possible explanation for why some people engage in more SIB, that they just are not don't have the same level of pain sensitivity, and so they're not getting that negative feedback from it in the same way. And so this is an area where still so much more research is needed to better understand, but it is one possible explanation for why someone might engage in SIB. And as you all are getting at with these great questions, there's a lot of possible causes and so many different types of SIB. And so it's a lot of trying to figure out why it happens for one specific individual. If it's serving a self-soothing and useful function, we don't need to change it. If it's causing harm, then we might want to. We had a question about picking at head or scalp causing tissue damage, not just pulling out hair. We do have a skin picking item in the DARP, which could get at the picking at the head and scalp. Another great question. What are the options to control SIB behaviors like nail biting and self-scratching in autistic kids? So this is a great question. I saw that this came around 1023, so I hope that the second half of the presentation that focused more on intervention strategies might have helped to answer this question. We're really trying to identify why it's happening for that person, trying to find other replacements. If it's a sensory function, is there something else sensory that would be as rewarding as that? If it's linked to anxiety, is there a therapy you could do to reduce anxiety? If it's a coping skill, does the person have any other types of coping skills? So it's a lot of trying to figure out why and then focus on what other skills we can build up. I am a non-speaker with autism who had severe SIB, and now I have no SIB. I type to communicate. Could any of the non-speakers or minimal speakers type to communicate? If not, the IQ tests are not reliable. This is such an important question. We are fairly limited in assessing IQ in people who have more limited speech. There are tests that do not rely on verbal speech at all and are completely nonverbal, but even so, they're limited in their capacities. So it's an area that needs more work, better and more reliable IQ tests for people who are non-speaking. And while I don't know whether in this sample the non-speakers or minimal speakers type to communicate, that is definitely something that I would be interested in looking at, because if you have another way to communicate and communication was the primary function of your SIB, the primary reason why you were engaging in it, then having a way to type could be the replacement that ends the SIB. A question about the age and IQ minimums to use DBT for SIB. This is a great question. So I appreciate the question about DBT because this is something that I have really been thinking about more recently, but I should be clear that as far as I know, and I'm pretty familiar with the literature on this topic, there's nothing that's been published on DBT for SIB in autism, though there are some new studies coming out trying to just more broadly look at whether DBT is effective in autism. So there's not any specific guidance around what the age and IQ minimums would be. I think most likely for an individual to be able to engage in DBT, there needs to be a certain level of language. So, probably like phrase speech to full sentences, and probably maybe like 7 and up or so. If somebody is non-speaking and has more severe intellectual disability, the DBT strategies might be more useful for their parents to be aware of, but they themselves might not benefit from that type of therapy. It is a talk therapy that, again, was originally designed for people with borderline personality disorder, but then has been used a lot more widely with depression and suicidal behaviors. And I got a question about my clinical practice working with people with autism. Do you use talk therapy or other modalities? So I pull together a lot of different modalities. I would say that I do a lot of parent training work, and so with my patients who are non-speaking, it's a full family therapy type of approach. But I would say that I integrate from behavioral therapies such as pivotal response treatment. I integrate from cognitive behavioral therapy. I integrate from parent-child interaction therapy. I integrate from research units in behavioral intervention or the Ruby manual that I mentioned. I integrate from DBT or dialectical behavioral therapy. So I'm bringing together a lot of different modalities. If the individual is capable, it might include talk therapy, but it's a lot of broadly looking at why behaviors are occurring and then thinking about replacement behaviors. A question about what happens when labeling triggers them. I'm thinking that this is referring to emotion labeling. And yes, some people do not like having their emotions labeled. And if that's the case, it might not be as useful for them. Still, the research tells us that knowing what our emotions are is an important first step to then being able to cope with them. So it's hard to use a coping skill if we don't think anything's wrong. And so you might try new creative approaches to labeling, changing up how you do it, um, doing it in a really calm and soothing voice, reducing the frequency of labeling, or just labeling it in yourself. But if you notice that it always makes them more dysregulated, you might want to try a different approach. Okay, looks like we have about 5 more minutes. I will try to speed through them. Just really quickly, I see we have a question about ABA and whether it's considered abuse. And I am aware that many autistic humans have viewed ABA as extremely problematic. I am really sorry for hurtful and harmful ABA experiences and recognize that anyone who had an ABA experience that felt invalidating would definitely feel that way. And the hope, my hope is that when ABA is delivered well, it's in a person centered, strength based way. Again, I know that not everyone has had that experience. For some people, ABA is very helpful and teaches them very useful skills, and other people report that it was abusive or not helpful. And so there's a very, very wide range of experiences with it. And definitely important to recognize that for some people, it was not a validating experience. There's a question about whether SIB is a response behavior or whether it can happen alone or in a relaxed environment. Research definitely shows that for some people, SIB happens alone and in a relaxed environment. And for in those cases, it might be that the SIB itself is just very reinforcing for that person. So it's not always necessarily a response to something. Huffing and loud exhaling, are those a response to emotional distress or frustration? They definitely can be. They could also potentially be a coping skill if it's happening in a paced and soothing way. But if it's really fast, then it might just be increasing anxiety. Question about what is PCIT? Yes, parent-child interaction therapy, if you're interested in looking it up. A question about headbanging and epilepsy. I think this is another area of research where we need to look more into links between seizure activity and self-injurious behaviors. And that's definitely something I'm interested in looking at. That goes along with what people have mentioned about looking at pain management and other medical conditions in relation to SIB.